Dr. Pranav Sheth, Medical Advisor for Sun Pharma. I welcome you all to today's virtual meeting on the highlights of the Day 1 of International Diabetes Federation 2025 conference. We are thrilled to have you join us as we delve into the key takeaways and groundbreaking discussions from this prestigious event of IDF 2025. The IDF conference is a cornerstone in the field of diabetes research and care, bringing together experts, researchers, and advocates from around the world. This year, the conference once again provides us with invaluable insights and innovative approaches to tackling diabetes. Over the next few days, we will be sharing the most impactful discussions with you. We hope this virtual meeting will not only inform but also inspire you to contribute to the ongoing efforts in diabetes care and research. Having said that, let me take this opportunity to welcome our chairpersons and distinguished speakers for today. A chairperson for today, Dr. Ganpati Bantwal, sir, is a professor, former head of Department Endocrinology, St. John's Medical College, Bangalore. Past President, Endocrine Society of India, past Treasurer, Karnataka Endocrine Society, past Secretary of Endocrine Society of India, past Vice President, Endocrine Society of India, and past Joint Secretary of Karnataka RSSDI and past Vice President of Karnataka RSSDI. Sir has received many prestigious awards and published more than 100 articles in national and international journals. Sir has been principal investigator in more than 80 clinical trials. Another chairperson for today, we have Dr. Devmalya Sanyal, sir, Professor, Department of Endocrinology, KPC Medical College, Jadavpur, Kolkata. Conjoint Professor, School of Medicine and Public Health, University of Newcastle, Australia. Visiting Senior Consultant, Endocrinologist at GD Diabetes Institute, AMRI, Kolkata. Sir is a Donald D. Etzwiller International Scholar with 85 publications and presentations worldwide. Sir is an editorial board member of World Journal of Diabetes and the reviewer of national and international journals. Sir has been involved in a number of international clinical trials in the field of endocrinology. Our eminent speakers for today, Professor Antonio Ceriello, sir, is a head of department of diabetes at IRCCS Medica Milan, Italy. President of the European Association for the Study of Diabetes, a group which studies diabetes and cardiovascular diseases, has been a member of board for the development of new European Society of Cardiology guidelines on diabetes, pre-diabetes, and cardiovascular diseases, developed in collaboration with EASD. Sir has served as Associate Editor of Diabetes Care Journal from 2003 to 2011 and Associate Editor for Diabetes Medicine from 2005 to 2016. From 2016 onwards, has been appointed as Editor-in-Chief for Diabetes Research and Clinical Practice, the official IDF journal. Professor Ceriello has published more than 450 original articles. Our next speaker for today, Professor Dr. Roden Michael, is a Scientific Executive Officer, German Diabetes Center. Sir is a Chair and Professor Endocrinology and Metabolic Diseases at Medical Faculty, Heinrich Heine, University Düsseldorf, Germany, and a Director of the Department of Endocrinology and Diabetology at the University Hospital Düsseldorf. Internationally recognized expert in diabetes, metabolism, and endocrinology, leads pioneering research connecting cellular biogenetics, mitochondrial function, and metabolic control in human diseases. Sir is a principal investigator in multiple EU-funded and national research network trials. Has been author of more than 600 peer-reviewed publications world and widely cited in the field of diabetes and metabolic medicine. Has been a key contributor in international organizations like EASD and German Diabetes Society, and has been recipient of prestigious honors in excellence in clinical research, academic leadership, and scientific innovation. Sir has been involved in actually shaping clinical guidelines, public health strategies, and personalized care models for managing diabetes and metabolic disorders. Thank you, doctors, for joining us today. I hand over the session to the chair for taking the session forward. Over to you, sir.
I think Dr. Antonio, you will be speaking first. Okay. Dr. Rod? Yeah, please start the proceedings. Over to Dr. Rod.
Yeah, thank you very much for the kind introduction. I'm ready to share my screen. If you give me 1 second. Do you have my screen?
Yes, it's visible. You are audible.
So, first of all, thanks go to Antonio, the co-speaker of today, who is actually the director and the president of this IDF conference in Bangkok. And he organized a great meeting, and I'm happy and was honored to be one of the stream leaders of the program, particularly in the field of basic and translational research. And I will be reviewing a little bit about some highlights of today's presentations. I would like to start with what comes before diabetes, pre-diabetes, and it's actually a session that we had today where Professor Birkenfeld from Tübingen in Germany was addressing the concept of remission of pre-diabetes. So first of all, as you know, pre-diabetes is also globally increasing, and particularly in Southeast Asia, there's a very high prevalence of people with impaired fasting glucose tolerance, more than those with impaired glucose tolerance, where actually the Asian population is rather on the low side compared to Western civilization. And he is the PI of a pre-diabetes lifestyle intervention study within the German Centers of Diabetes Research, where he is one of the partners, and also my institute is one of the partners. And he found that in high-risk pre-diabetes, it definitely needs intensified lifestyle intervention to be more effective in a regression to normal glucose tolerance in this high-risk population. There's something what is kind of interesting. So if you do studies, what he did to achieve a weight loss of at least 5% of body weight, you actually get a nice improvement of insulin sensitivity, reduction of liver fat content, and also improvement of islet cell function. However, only those people who achieved weight loss plus regress to normal glucose tolerance, those were actually also having benefits with a marked improvement of insulin sensitivity, visceral fat reduction, and what is more important, a lower risk of early signs of kidney complication and small vessel integrity. So making the point that weight loss alone is not enough, but also reduction of glucose to a normal glucose regulation. And that is, of course, important for definition. How do we rate pre-diabetes remission? And there's actually ongoing initiatives for a guideline, at least in Europe, by the EASD, and to have a set point criteria for a remission, which would be fasting glucose of 100 maximum, or actually below 100, a 2-hour plasma glucose concentration below 140 milligrams per deciliter, and also a reduction of HbA1c down to 5%. So that was more or less the take-home of this important presentation. I also would like to highlight some of my presentations of today, where we were actually showing data on precision diabetology. So that goes back to the German diabetes study, which is an ongoing study started in Düsseldorf, but is now also a German study. And when we applied the criteria that have been initially introduced by Dr. Alquist and Leif Grob and colleagues, we actually found that our diabetes cohort, this is a cohort of new onset diabetes people, can actually be in a similar way subtyped or subgrouped into people with different subtypes of diabetes. What is more important, that there is one of these subtypes, the severe insulin resistant subtype, that shows the highest risk for early nephropathy and nephropathy progression, for steatotic or fatty liver disease, whereas for peripheral neuropathy, the severe insulin deficient subtype is much more at high risk. There's also in male people erectile dysfunction, which is seen both in the severe insulin resistant and insulin deficient phenotype. Again, as for nephropathy and fatty liver disease, cardiovascular disease is highest in the severe insulin resistant phenotype. And what is getting more and more interesting and important is that the insulin resistant subtype is also the one with the highest risk of sarcopenia. Why I'm introducing this is why we just from this study published data on this German diabetes cohort, which is a prospective cohort with a follow-up of now up to 20 years, early signs of retinal abnormalities in structure and microcirculation. And first of all, we show that even at the beginning of diabetes, without any kind of clinical signs of retinopathy, we already see abnormalities in the choriocapillaris flow deficit. And we see differences in the superficial capillary plexus with regard to perfusion density and vessel density. And as you can see here, in this case, it's interestingly the severe insulin deficient subtype as well as the moderate obese subtype, which shows abnormalities on top of the changes that occur with aging and duration of diabetes. So this is what we have from that. We actually now offer a diabetes calculator on the internet, which allows by entering key data to identify the risk for subtyping. And in this case, it's the purple, the moderate age-related subtype, which is the one which can be, for example, also identified by this online tool. There's much more to come with regard to physical quality of life and novel types of even improving this subtyping of diabetes. And so precision diabetology, we are still, I would say, in the middle, and a lot of many questions have to be solved. And part of these challenges have been addressed by a very nice presentation by Dr. Anjana from India, she is from the Dr. Mohan's Diabetes Specialist Center, and she addressed ethnic differences in a specific session on ethnic differences. And I think I do not have to tell this audience that India is at specific risk of high prevalence of diabetes, generalized obesity, as well as particularly abdominal obesity. And what she showed was, in analogy to what I showed you for these European cohorts, that there are also 4 subgroups of type 2 diabetes in Indians. And there's one that has this severe insulin deficient diabetes, very similar to the European subtype. There is another one, which is the so-called MARD, the mild age-related subtype, again, very similar to European, but there is particularly one subtype, the CIRDD, the combined insulin resistant and deficient diabetes, making the point that there is a group that has both a severe insulin defect, abnormality, as well as severe insulin resistant, and is at the highest risk, most likely, for complications. So that was her conclusions. I think the most important conclusion is that there is a South Asian phenotype with these combined abnormalities, which is this excessive risk of complication and needs careful management and prevention. From that, I would like to move to a session on the gut-brain interaction and communication, where we had Professor Nieuwdorp from Amsterdam in the Netherlands, who in his studies interestingly found that the gut microbiota differ even within one country, in the Netherlands, between the Caucasian and the Surinamese population. That is shown on the left side. The red one is the Dutch, Dutch population. The right side is even more important because he then analyzed these over the generations. And there's these red and blue bars showing that compared to baseline in the first, let's say the baseline is the first generation, the difference in the taxonomy, that means the distribution and composition of microbiota, is not only seen in the first generation, but is maintained over the second generation, making the point that microbiota are something that is very important and not so variable as some people might believe. Microbiota are important. He showed data that actually our own gut microbiota can lead to ethanol intoxication. So you can get drunk by your own microbiota if you have some risk, which is metabolic syndrome and NASH, which means the non-alcoholic, nowadays we say metabolic dysfunction associated steatohepatitis. It's the red line on the left side, which is important. So if you have a metabolic fatty liver disease and you ingest a mixed meal, then your ethanol levels actually reach levels of a moderate drunk person. And the role of the microbiota is nicely illustrated that if you give people with this NASH syndrome an inhibitor of alcohol dehydrogenase, this 4-methyl pyrrosol, then actually you see that the alcohol, which is normally metabolized, accumulates, particularly in this risk group. And this is abolished if you give antibiotics to these people. So showing that it's really the endogenous ethanol production. The other thing he pointed was the role of serotonin. Serotonin is not only made and active in the brain, but also produced in the intestine and secreted and ends in the brain. And he showed that by a combination of a SPECT MRI study, and you see here in the location of the serotonin receptor expression in green in the thalamus and in red in the hypothalamus. And when he, in this study, gave oral butyrate to the people, that is actually known to downregulate the serotonin receptor binding, then he actually can reverse that by FMT, which is a fecal microbiota transplantation. Nowadays, this can be done by capsules, so it's more tolerable. And again, makes the point that the microbiota and the composition of the microbiota is also important, or may be important, for brain neuronal signaling, as shown here. From that, we move to a presentation by Professor Salles from Sao Paulo in Brazil, who reviewed the incretin concept. I think it's to this audience not important to review all the issues of the incretins, but particularly for the rest of my talk, it will be about the GIP, which, as you know, is the main component of the tirzepatide, which is one of the most efficient weight-losing drugs at the moment. And the GIP, as you know, is secreted by the K cells of the upper intestine. And what he nicely summarized based on all the data is that the GIP is the primary responsible for the incretin effect. That means the adequate more secretion of insulin during a glucose tolerance test or during a mixed meal test. And this is much more compared to GLP-1, and there's an additive effect if you add GIP to GLP-1. He also made the point that the GIP has peripheral effects, and one of these peripheral effects is that it actually activates lipoprotein lipase located to the adipose tissue, which drives the uptake of fatty acids into adipocytes and improves storage and reduces the release of fatty acids, and thereby also contributes to improvement of insulin resistance. However, I just would like to mention that there's a very new paper that just came out a few weeks ago in Cell Metabolism showing that when GIP binds to its receptor in the adipose tissue, it actually causes heat production, which is mediated by calcium signaling, something which might explain at least a certain percentage of the effects of GIP agonism by improving thermogenesis. And with this, coming to the last one, which is probably the most experimental, which was given by Professor Müller from Munich in Germany. He's one of the leading, let's say, preclinical pharmacologists dealing with these co-agonists since more than 10 years. And he showed data which is now mouse experiments. So what I showed before was the humans. Now, at the end, we go back to the mice. he showed in papers, one of them already published, the rest of the data is in press, but not released at the moment, but he allowed me to show that data. He showed that the GIP decreases body weight by its neurons, which is fair to say. So for example, on the left side, you see normal mice. They receive in red the GIP, which decreases body weight. In white, you see GLP-1, which under these conditions is more effective than GLP-1. And you see an additive effect by a co-agonist here called MR709, which is a GIP-GLP-1 agonist. If you then knock out the GIP receptor, then all of this effect of the GIP is lost. And then the co-agonist is not more effective than a simple GLP-1 receptor agonist. Now it gets a little bit more interesting and complicated. He and also others already found evidence that not only a GLP-1 agonist, but also a GIP antagonist is active. So the right side again, you see in white GLP-1 agonist, this causes a weight loss. And if he gives a GLP-1 plus a GIP antagonist, there's an additive weight loss. And if he then knocks out the GLP-1 receptor, then you see still an effect with the GLP-1 antagonist. So making the point that GIP antagonism can also lead to weight loss, but it occurs by a different way, not by the brain GABAergic neurons. And the last one, to make it even more complete, is that he is asking the question, is the GLP-1, if it's part of a co-agonist, differently acting compared to a simple, straightforward GLP-1 receptor agonist? So he gave semaglutide in these mice to induce a weight loss. And this is the blue line. You see the delta body weight, again, reduction of body weight by about 20%. And then he gives a semaglutide, which is modified in a way that it looks like a co-agonist. And in this case, you see that the effect is even more. So the GLP-1 bound to something else seems to be more active than a GLP-1 receptor agonist when it's working alone. Making it even more complete, so GIP has a pro and let's say an agonist and an antagonist version. Both can be active, and GLP-1 activity is not based on the receptor alone, but probably how it's modified. With this, I would like to thank you for your interest and your time, and I'm ready to take questions whenever you want. Thank you.
So I think we can take the questions at the end after both the eminent speakers have given today's different, very interesting new emerging data. So we'll probably would ask Dr. Antonio to go ahead with the presentation, and then we can have a very good discussion at the end. Over to you.
Yes, thank you. Welcome from the remote site. Many already know that unfortunately it was impossible for me to join the Congress program of which I've managed for urgent surgery, but it seems that it's going very well. So Professor Roden anyhow already covered several aspects of today, but there is, in my opinion, one or key event during this day, which was the final launch of the IDF Global Clinical Practice Recommendation for managing type 2 diabetes. So something which is new. This recommendation, which we do not want to define anymore as, let's say, guidelines, because of course the process for guidelines is different. But you see, anyhow, they involved a lot of experts, not only as core contributors, but also as external reviewers. And also, I really wish to share with you that this was an initiative of the Professor Akhtar Hussain, who passed away some months ago. We were working together on this project, and I and Professor Colagiuri have continued, let's say, his mandate in finalizing something that in time was more complicated than believed. Why to have new guidelines or recommend clinical practice recommendation coming from IDF? Because first of all, the target audience is of course intended to be any healthcare professional involved in the management of people living with diabetes. But this important, more maybe not less important, these guidelines are also settled to be read by the policymakers who are responsible for healthcare services. And why? Because, in many countries, the IDF guidelines are used as line, in driving the choices of the healthcare systems. And we did not want to lose the opportunity to give the possibility to people living with diabetes to have an instrument in order to get the best available situation. We were updating, we were lucky because they are the last guidelines coming out. So we were working on new medication, evolution diagnostic tests, because there are new interesting diagnostic tests, of course also on the new technology. And what are bringing these recommendations? Are bringing updated data, are bringing the concept of integration of care, in that particularly in resource-constrained settings, where resources and personnel are stretched in. They also have a contemporary framework, which provide HCPs and the policymakers with an up-to-date framework for navigating complex diabetes management. And they are global they have a global relevancy applicability, which is the main goal of these recommendations, because until now, the most appreciated guidelines are coming from the United States, from Europe, but we know very well that what is good for these continents very often is not simply possible to simply share in any other part of the world. And this is why we decide to have two levels of the care, optimal and the basic. Which means optimal care? Means evidence-based care the prevention provided in well-resourced settings. Please pay attention, we are not speaking about countries, we are speaking about the settings, meaning that in some countries there are settings which can afford or not to have high-level care, while in other countries this is not possible. A basic care is evidence-based care prevention adapted for resource-constrained setting, a starting point towards optimal care. Target audience are, of course, HCP and policymakers in well-resourced setting, and on the other side, basic care, the target audience is the same, because that this is the accommodation set for them. What about accessibility? All in the optimal care, the idea is that the accessibility belongs to all individuals with at risk of diabetes. In the basic care, essential care for all individuals regardless of resource limitations. Scope: comprehensive, individual, centered, multidisciplinary care, decision support system in the optimal care. In the basic care, focus on essential services and priorities programs adapted to challenge of a local healthcare setting, individual-centered, best available multidisciplinary care approach. But let's move to the chapter list. You see, we try to cover the most important aspect of type 2 diabetes management today. We are not entering more in details, of course, in other aspects of diabetes management, because otherwise there would be a nightmare more than it was. So in the type 1, we were working on detection of diabetes and intermediate hyperglycemia and prevention of type 2 diabetes. You see that we are not speaking about prediabetes, we speak about intermediate hyperglycemia, which is the new definition that the WHO is launched, the IDF adopted to define prediabetes. And these are the recommendations. The options for screening for diabetes and intermediate hyperglycemia are no different in optimal care and basic care. There are some risk scores, risk factors, the evaluation risk factors. There are basic biochemical testing options, starting for fasting plasma glucose, going to 1 hour post plasma glucose during a 7-hour GTT, which is an emerging option, which also was presented today at the Congress. So clearly, the screening protocol will be selected on the available resources and capacity to intervene in programs with diabetes prevention. What we can do for the prevention? In optimal care, of course, there are more possibilities to have a structural lifestyle modification. We suggest use metformin as an additional intervention. You need to provide a reassessment of regular reassessment of individuals, and support the program with a data system, and regularly monitor and evaluate the program. Basic care, consider if you can do this, and then act. At the level of population, there are several possibilities, as you can see here in the slide. So this is a possible algorithm starting from the risk factor-based screening, meaning do you have a clinical risk factors or risk score, and then you go down, down, down in order to better define the clinical situation according to the tests you can use and the level of risk you have. But what about the glycemic control assessment and targets in type 2 diabetes? I think that we have again two level of dimension of recommendations. We have the optimal care, but you see that the measure of A1C at regular intervals is mandatory in any kind of approach. And the only difference is if A1C is say not available, as in many countries, use any available glucose measure. Measuring glucose is in any way is better than do not measure. Then, very important is the use of CGM, because you see here that in the past we had very strong evidence that the self-monitor, the SMBG is very helpful in keeping the good control of people with living with diabetes. The targets are the targets that IDF defined some years ago, and there is no reason to change them. Then we have also the possibility to use continuous glucose monitoring. And the news is that CGM may be considered not only in type 1, of course, with the on insulin therapy, and type 2 on insulin therapy, but also in others on individual basis. When you consider that the CGM can be useful for education, or for to improve the awareness, so to help you to choose the best therapy, you can use a CGM in optimal care settings. But there is also the possibility to have short-term CGM in selected people with type 2 diabetes on if in the basic care settings, if the CGM is available and affordable. What about blood glucose therapies? I think, of course, lifestyle modification is not under question. But in presence of no complications or very low cardiorenal risk, we also suggest that the combination therapy is an option, particularly in optimal care. You see that this is a very modern approach that at the moment no other guidelines is regularly recommending. And in the basic care, considering that if there is nothing, is not possible to have, there is no availability of other drugs, clearly metformin remain being the cheaper, the first choice. In obese persons, we suggest that in the optimal care to use metformin and GLP-1 receptor agonists. In basic care, metformin plus SGLT2 inhibitors, which in many countries are now more affordable. In presence of cardiorenal complications, of course, lifestyle modification, both settings, metformin and SGLT2 or GLP-1 receptor agonists with the preferential use on SGLT2 inhibitors in presence of heart failure. So about optimal care. Basic care, metformin and SGLT2, which are now, like really, we cannot avoid the use of these drugs. So, but this is at the diagnosis, but in preventative therapy and not at the glycemic target, you must reinforce lifestyle modification. And if not, only on metformin, add SGLT2 inhibitor in optimal care, or in obese person a GLP-1, or if on combination therapy, add preferentially an SGLT2 inhibitor or GLP-1 receptor agonist in the optimal care, while you see that on the other side, in the basic care, there is not only on metformin, add an SGLT2 or any other blood glucose lowering therapy available. While if for radio combination, add an SGLT2 inhibitor or any available blood glucose lowering therapy. While the person is at risk for cardiorenal and only on metformin and not a target, again, in the optimal care, the situation is not different from what we suggest in presence of no complications. while in the as well for basic care. So as you see, the possibility of today to have SGLT2 inhibitors in many countries, not at very high cost, has changed the approach in terms in higher optimal care and in basic care. We can offer a good opportunity and a good choice, and this guide, this recommendation, I'm to help to discuss with healthcare systems in order to get this. And then you at the end, the recommendation, you find these algorithms which can help in driving the choices. Then there are the insulin options therapy. Then we speak about insulin initiation, begin insulin, about optimal care, begin insulin therapy when optimized glucose-lowering medication, lifestyle changes are not maintain target blood glucose control, and also while in basic care, begin insulin therapy when optimize available glucose lowering medication, lifestyle intervention, do not maintain target blood glucose control. Then you need a support. This is very important when you starting insulin. Then monitoring is mandatory when you use insulin. And then there are there's really a broad range of insulin delivery devices, a kind of insulin. You can choose the best when you need. And then you see here a scheme for insulin cessation and insulin intensification. And you see here that not following what other guidelines are recommending, we have still a room for premixed insulin, which are very popular in many Asian countries, and not mandatory to use a GLP-1 receptor agonist. Of course, you can use, they are good, and you are the player in order to decide when they are useful. What about weight control? The lifestyle change clearly is the basis. There is no fact that this works in any kind of settings. You can use very low calorie diet, very low calorie diet in optimal care, a low calorie diet in basic care. Honestly, probably in the basic care, the low calorie diet should be already there for some reasons, but we do not want to push too much the low calorie diet, considering the different setting, but also the culture. While in optimal care, the possibility is to use incretin basic therapy or metabolic bariatric surgery. While in basic care, you can use weight-sparing blood glucose therapy and SGLT2 inhibitors if available, meaning that because GLP-1 are very expensive, an alternative, other drugs are also showing a body weight reduction action, of course, not so extreme as GLP-1, but consider that also SGLT2, they have this property. Then, of course, you have to improve the diabetes control in the case of people when you want the weight reduction. So weight reduction accompanied and improving diabetes control means lifestyle changes, incretin basic therapy, metabolic bariatric surgery in optimal care, lifestyle change, metformin, or add weight, any kind of therapy indicated, particularly an SGLT2 inhibitor if available. What about obesity prevention in people obese? Lifestyle change again, consider metformin, SGLT2 or increase in basic therapy, but particularly metabolic bariatric surgery, which already has a very solid literature. In basic care, I think that we can only consider to add metformin. And the new chapter, Professor Roden already discussed about this, is the possibility to have diabetes remission. At the moment, we know only the possibility about a low calorie diet, and particularly also use on bariatric surgery. So this is something that can be used in optimal care and in basic care, where metabolic bariatric surgery cannot be used. There is a different approach, starting with low calorie diet or intensifying with very low calorie diet. What about cardiorenal protection? Oh, we learned a lot in the last years. And then, of course, we needed to screening and so on, but also we need to consider other aspects: glycemic control, risk factor control, blood pressure, lipid control, consider aspirin, SGLT2 or GLP-1 receptor. So there are so many possibilities. About basic care, you have glycemic control, risk factor control, blood pressure, lipid control, consider aspirin or SGLT2 inhibitors. Then there are several ways to, this was something new, what are we suggesting for the screening of the risk assessment? I will not go in details because otherwise I will use all the time I have, but also in management, you see that now we have a lot of opportunity, and particularly also the new data related to possibility to have a non-steroidal mineral corticoids or a GLP-1 receptor agonist or tirzepatide, also for heart failure and kidney disease, is really interesting. And so in optimal care, they should be considered, which is not the case, for example, in basic care. And again, in chronic kidney disease, it's mandatory to measure the GFR and the urinary albumin excretion rate, and also to control all the other risk factors. And then we have now important tools for the management of kidney disease in these conditions. So you see here a scheme as a hyperglycemia is still central in the management, in the development of complications. And these are the 4 pillars of diabetes management: education, lifestyle modification, weight control, monitoring, review, early intensive glycemic control, early multifactorial risk factor intervention, additional cardiorenal prevention. All these together will contribute to control the risk for development of complications in diabetes. I stop here to get give a possibility for some questions.
Excellent presentation, I think. Again, very impressive, all-encompassing, guidelines, especially, very practical guidelines, especially when we look at the glycemic, the weight part, where GLP-1 may not be affordable to a large section of the population. Though in India, we now have the opportunity of using the GLP-1, which are biosimilars as well, but still they are still costly, much less costly than the originator brand. Again, with regards to the insulin, the premixed insulin option is still there. The other guidelines having omitted that as well. Yes.
It is such, yes.
Yes. Do you have any guidelines?
I didn't find.
Yes.
Okay, just one more comment. I didn't find the chronic kidney disease, the non-steroidal mineral receptor antagonist. That was not there in that guideline.
Sorry?
The finerenone was not included in the chronic kidney disease guideline.
No, there is, yes. No, there is a mineral corticoid therapy. There is. We use the mineral corticoid therapy because finerenone is very, very effective, but it's not the only one available. So you cannot say, but it's there. It's there. Sorry, when you have only few short time, no, you cannot go. But if you read, of course, any chapter is accompanied by a huge description of what was building. The guide, his recommendations, of course, you find that the literature, the motivation, and so on. Oh, and because the guidelines are from today online and are free available on the RCP, Diabetes Research and Clinical Practice, I invite all the audience to download the guidelines in order to have an extensive, if they are interested, an extensive test of extensive paper of the guidelines.
One question is with regards to the use of CGMS, even in patients with early insulin, not even complex insulin, recommending, especially in optimum care. So how far is it justified to regularly use CGMS? So what is the current recommendations with routine use, regular use of CGMS in all insulin-treated patients in optimum care?
You will see that there is a recommendation they use when needed, which means you choose, because there are several factors that you find in the test influencing the use of CGM. First of all, the availability and the cost. For example, maybe you will be surprised, in Italy, we have 3 regions, because we have 21 regions, all independent. They are offering for free CGM in type 2 diabetes, not insulin already. Why? Because the goal is to improve the education, because particularly diagnosis is very helpful, that people can learn what is useful and what not, in terms of, for example, food, or also if the therapist is functioning, or to use the CGM for short period when something is going wrong, and then the doctor is selecting the better option. So, don't you find this in the guidelines?
To Dr. Roden, you spoke on the cluster classification of diabetes, and you spoke on the severe insulin-resistant diabetes. So what are the treatment options? Like you want to use a GLP-1 or you want to use metformin? Is there a role for pioglitazone at all? Because Refluxo says the only sensitizer is pioglitazone. So what's the comment on this?
That's a very good question. So the first and easy answer is that we have at the moment only one prospective study that has investigated one GLP-1 receptor agonist, semaglutide, against one SGLT2 inhibitor, dapagliflozin, both in a severe insulin deficient and a severe insulin resistant group, the one you were addressing. And I tell you, in both of the groups, regardless of the subtype, the glycemic control as an endpoint was better with the semaglutide compared to the SGLT2 inhibitor, although that was also efficient, but there was no difference. However, when they then, going back from this phenotype-based clustering, did something like an unbiased reclustering, they found differences based on hypertension, comorbidity, kidney function, starting HbA1c, so a large number, making the point that at the moment, we need still much to learn. There is another study which is based on this UK trial master concept, where they used similar information in the subtypes, and they actually came up to differences between different drugs. But this is still, I would say, open for discussion. I think for the moment, what we can say is that the severe insulin-resistant phenotype and the one in India, which combines both severe insulin deficiency and insulin resistance, I think the most important we can say at the moment is early tight management and screening. So try to screen for insulin resistance and try to do the best you can do. So if I look to the guidelines that Antonio just presented, even in the lower income countries, if possible, this is the group that should have more attention because they are at high risk early on, compared to the vast majority, where probably even in the high income countries, we could be a little bit more relaxed. But that's my personal view. That's not the guideline view. At the moment, as I say, with regard to treatment, very difficult to make a judgment, but with regard to prevention, early diagnosis, looking for the kidney, looking for the heart, looking for the liver, this is the group we should pay attention to.
The question with regards to the pre-diabetes, the first one, a very interesting data, because there is such a hue and cry with regards to obesity being the, addressing obesity being panacea for everything. A very important thing which you mentioned was the glycemic control as well as the weight matters. Especially, how do you put that, means how you look forward with regards to medications which are available and its impact and management with regards to this aspect?
Yeah, so as you know, the GLP-1 receptor agonists are also potent with regard to insulin secretion. So if available, they might even have a stronger argument in the pre-diabetic obese people, which doesn't hold true for other drugs, except for DPP-4 inhibitors, but they don't have any weight efficacy, so they fail at the first line, which is reduction of body weight. So point is that I think that reaching the glycemic targets will be even more difficult when it comes to drugs. So I think we should rely on intensified lifestyle modification. So this is still the group that will benefit with regard to lifestyle modification. And we need to do more on a more, let's say, targeted and individualized way, and also need to learn more on the subtypes. So they are actually now doing also studies who is responding best with regard to the lifestyle intervention. And there's an ongoing study where we are working together with the Tübingen group, actually looking into different dieting rhythms, so intermittent fasting. So if you do an intensified lifestyle intervention, and different chronotypes probably might play a role, and we are checking this in the subgroups of prediabetes. And we will probably learn more next year or in 2 years if this is specifically effective. I actually did not address the one part of the last question on the insulin sensitizers. I think there are now new insulin sensitizers actually coming up, particularly in the field of steatotic liver disease, which is the PAN, PPARs, and the mixed that were out of business for, Antonio might remember and you might remember. There have been a lot of attempts, something like 15 years ago, and they failed for cardiovascular complications and toxicity. There is new developments that actually work particularly on the liver. And by this, they improve insulin sensitivity. And there is probably one option for these drugs in the future, because they do not lead to weight gain. They improve one of the major aspects of the early on disease, which to me is the fat in the liver. It's not the fat triglycerides per se, but all what comes with that.
We already have one molecule which we are using, saroglitazar, the pan-PPAR.
Yes.
We have been using that. One very interesting thing which you mentioned with regards to the effect, all with GIP is still very confusing. One is with regards to the adipose tissue, with regards to the prevalent knowledge of improving the fat partitioning. The new thing which you mentioned was this increased metabolism with regards to in the adipose tissue, and as well as the GIP agonism and antagonism, how it balances out.
Yeah.
I think that is somewhat a little bit of still evolving. What is your take on that? Clarity.
So I would say, first of all, we need to be careful that probably not all of the mouse data can be translated to the humans.
Correct.
However, having said this, I was personally very much surprised about the translation of the weight loss percentage from the mice to the humans. When I first saw these data from the mice 12 years ago or so, I said it would be never possible to have more than 15% weight loss by a drug. Turns out it's possible, up to 25%. So we can learn from the mice, but probably not all of that. I personally, I have the feeling that these peripheral effects of GIP-1 may be very important to explain this additional or separate effects from the GLP-1s. And it's not only this one paper that I showed to you briefly, it's a number of different papers actually looking not only into fat uptake into adipose tissue, but actually burning it. Because different from pioglitazone, for example, where let's say the healthy fat is accumulating in the subcutaneous adipose tissue, these people don't accumulate the fat. So they probably have this nice way of taking more fat up and also burning it. And I have to say one of my conflicts of interest is that I believe that the mitochondrial function is definitely a main target, not only in the liver, where it's now addressed also with drugs, but particularly in the adipose tissue.
Yeah.
GIP antagonism. Yeah.
Yeah. In the optimal care, you told the preprandial values are between 70 to 144. Previously, it was 70 and it was brought down to 80. So they brought it down to 80 and it was between 80 to 130 preprandials. Now in the guidelines, they say 70 to 144 for optimal care. So what's the rationale of bringing it to 144? That's number one. And why did they go down from 80 to 70?
To have these new targets is coming for some papers, particularly also from one of our paper published few months ago in Diabetes, that a more stringent targets are important because what the current targets are recommending are not accompanied by zero risk. So the idea is do your best if you can. So this is very, sorry, just to simplify because of the time I think is over. Oh, it's an hour and a half. I do not remember how much time is scheduled for this meeting. But so the criteria is, and this of course you will find in the test, that the news is very important. It's mandatory more than before, because also this was recommended in the past, but the evidence, why we have the evidence. Between 5.7, for example, and 7 of A1C, we demonstrated that anyhow, there is an increase of 20% of cardiovascular risk.
Yeah.
So
yeah. That cohort study was there. I saw that, yeah.
So means that, okay, I understand the 7 coming from other studies, but in real life, you must be pushed to go down, more down, if it's possible. And with the new drugs, very often it's possible, because the problem was that when these targets were settled, these new drugs were not widely used, the hypoglycemia risk was high, and blah, 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 and so on. Okay, this is the scenario has changed.
To Dr. Rodin, you spoke about that auto brewery syndrome, the ethanol production. Can it happen with SGLT2 inhibitors also? You're muted. The auto brewery syndrome, you showed us a study where they showed there's endogenous ethanol production. Can that happen with SGLT2 inhibitors? I just remember seeing a letter to the editor in New England Journal telling that it could produce that.
There is no systematic studies on that, you know, so I cannot tell. It is possible. Actually, I can tell you that I talked to the speaker of this session, to Professor Newdorp, about the effects of the let's say more modern treatments, GLP-1s and SGLT2 inhibitors, and he at least what he disclosed is that the effects are not that dramatic as one would expect. That's the only thing I can say. That's expert testimony, and we don't have very good studies on that. We are actually addressing this question right now with a very classic old drug, which Antonio tells us is still important for diabetes treatment, which is metformin. Because we learn from not only from the old studies, but also from a study that we are just doing, that the classic way that we have in the textbooks, that metformin is decreasing gluconeogenesis in the liver, is probably only an effect that you see in people with high HbA1c, high degree of hyperglycemia, and it cannot explain different effects where we know that metformin definitely has gastrointestinal effects, side effects, but also probably beneficial effects. So possible, yes, but for the newer drugs, most likely not so important.
With regards to Dr. Antonio, how would you think that the 1 hour post-prandial will fare in the long run? Means with regards to other societies accepting that?
There was today a working group managed by Lancet DE. I'm sorry, I was the first. Yeah, I was the first. Because I believed in this, and IDF, I pushed IDF to work on this concept. We published a position statement last year. And now also the other societies were today in this working group, including ESD, and I have rumors that also ADA is interested, because the evidence is stronger and stronger that this is the best way for identify earlier, because the problem is not only that you spare 1 hour of staying in the lab when you perform an OGTT. No, if you check an hour, it's better to stay in the lab 2 hours. But 1 hour identify earlier people at risk for developing diabetes and also cardiovascular disease. So this is why there is a huge movement. And finally, I am also very happy that this is going on.
Can I add something to that, Antonio? That there is also evidence from a few studies that the 1 hour glucose is actually predictive of liver fibrosis in those with steatosis. So I hope this is also covered, because that might be relevant, also explaining this cross-link between cardiovascular, liver, and diabetes.
Because you are so fan of mitochondria, there is an old paper coming from Michael Brownlee group showing in vitro curves that 1 hour of exposure is enough to destroy the mitochondria, and a GLP-1 is inhibiting the process. So this is also intriguing, meaning that, okay, anyhow, this, the way is open. Let's see what happens.
I think that's all we know.
Okay, sir. So I don't think we have any further audience questions. Thank you so much for joining us today and sharing the highlights of the first day of the IDF conference. Our heartfelt gratitude to you, and your dedication to advancing global diabetes care is inspiring. With this meeting, we are reminded of the importance of global collaboration in addressing the global diabetic epidemic. And thank you, dear doctors, for joining us today in this meeting. With this, we conclude today's meeting. Good day to all of you. Thank you so much.
Thank you. Bye-bye. Good night.
Bye-bye. Good night.
Bye-bye.
Ciao, ciao. See you.
Thank you so
Recording
much,
stopped.
Mr. Raghu. Thank you so much. I'm really grateful that you could come and you could spend some time here in this platform. And
Oh, yeah. So, hello.
Thank you. I'll
Hello,
meet you.
Michael. Thank you. Thank you very much. It was really a wonderful performance.
Yeah.
Because I don't know how much you know the Indian colleagues. They are very active. They are used to make a lot of questions, and it's
Yes.
very pleasant. It's very pleasant, not very speaker. This.
I have been to India a few times, and that there were always very lively discussions, actually.
Yeah, yeah.
I want to
compared
invite you to come to India shortly, sir. Then please accept my invitation. Come to India shortly along with Professor Ciriello.
Yeah, would be nice. Would be lovely.
Yeah, yeah.
Ciao. Ciao.
Thank you. Thank you.
Ciao.
Thank you for your time. Yeah.
Bye-bye. And I see you tomorrow.
See you tomorrow, sir. See you tomorrow. Have a good night. Thank you so much.
Good night. Bye-bye.
Ajay ji. Good evening, Ajay ji. Hello. Ajay ji, are you there?